for that kind introduction. I'm just going to go ahead and share my screen here. Great, so today I'm here to talk about community engaged approaches to cancer prevention in the Somali community. And my goal for today is to not tell you about a specific project, but rather kind of give a flavour of the potential that we have that we can access and untap thinking about community engaged approaches to cancer prevention in general. So my hope is to give you some examples that give you some ideas about what might be possible, different kinds of projects that you could do, and have some discussion about some of the things that have been important as I've gone about this work that you might find useful for yourselves. So before I get going, I just want to share some acknowledgements. Community engaged work very rarely happens without the support of amazing partners. And I've been very lucky to collaborate with Imam Sharif Muhammad, Wali Dere, and Dr. Michael Van Keulen of the Islamic Civil Society of America, and other great partners such as Welshire International, Smiley's Family Medicine Clinic have been wonderful collaborators, a vast array of community members, and we've been very fortunate to receive funding for this work from places like the Program of Health Disparities Research, the Search Group at CTSI and Clearway, Minnesota, among others. And that's made all of this work possible. So by way of background, I've been engaged in this particular set of community engaged research here in the Somali community in Minnesota for probably about the last 8 years. And while not exclusively, most of our work is focused on cancer prevention. My background is I trained as a community psychologist in New Zealand. That's my original home, and I'm a social scientist. And I bring expertise in qualitative and implementation science methods, which has been very helpful for this type of community engaged work. So by way of background, the Somali community in Minnesota has had a long and challenging journey to settling in Minnesota. It's a very large and vibrant community. The estimates of how many Somalis have settled in Minnesota varies vastly, anywhere from 60,000 to 100,000 or more. And the reason that is hard to estimate is because while some people came and settled from outside the US into Minnesota, there's also a ton of internal migration where people have arrived in the US and resettled to Minnesota because it is such a large and vibrant community. When we think about health and wellness in the Somali community, it's really important to consider the importance of thinking about religion and interpretations of faith. This has a very big role in how we think about cancer prevention and how we promote health. And my experience of collaborating with the Somali community has consistently been that I've been met with enormously welcoming partners who bring a great deal of curiosity and motivation for change in relation to their work, and are very energized to partner for better health of the community. And that's a good thing because this is something that's greatly needed. These are, just a few snapshot statistics around cancer and cancer prevention in the Somali community. When I first started doing this work, one of the urban clinics who serves a very significant portion of the Somali community had a mammography rate of 8%, which is probably one of the lowest rates of participation I've come across in cancer prevention activities. That has over the years increased somewhat. But for me, that was a real entry into understanding the seriousness and the need for this work. We're also seeing things like HPV vaccination rates of as low as 10%. Colorectal cancer screening is another really challenging area where we see very low participation in screening. And cervical cancer screening is a little bit better, maybe around 45%. Sometimes it's less depending on the clinic. So these numbers change over time. It's quite mobile. And one of the things that we know is that when we can improve cancer screening rates, it's not a one-time effort. It's something that can improve and actually backslide. So the need to kind of work on these disparities is something that needs to be pretty sustained in order to really make a difference here. One of the things that I'll tell you a little bit about today is these are the values that we have embedded in the work that we have done in the community. So myself and the community partners I've collaborated with, we haven't focused on a specific or an individual diagnosis or body organ or particular idea. We've actually focused about prevention in general. And these are the types of values that really characterize our approach to community engagement collaboratively. And the first of that is to acknowledge the role of the importance of family. And we have a medical system, and in fact, medical research is much the same, that really centers the health and the wellness and our activities around individuals. And this is not the case for all cultures. So in the Somali community, really understanding and recognising the importance of the family as a unit for participation in cancer prevention is very important. We've also worked very hard to build and strengthen partnerships as a key to what we're doing. And that's to recognise partnerships might be very dynamic, they might change over time. And certainly these have changed for us over the last 12 months in response to COVID. So while we have done a lot of our work focused on cancer prevention, the fact that we had partnerships in place and relationships already built meant that we've also been able to put some of our focus into the impact of COVID-19 as well. It's really important to, as I was mentioning earlier, recognise the importance of faith. And to recognise the importance of faith is a real asset for health promotion. So one of the common challenges in working in this area is that the literature and providers often report that faith is a real barrier in engaging Somali community members in cancer prevention. And what we've found in our community engaged work is it's actually also an enormous asset for change and an asset for health promotion. So that's a value that's been quite central to the work that we have done, is to be faith inclusive. The other key thing that characterises our community engaged work is to really lead with assets and not deficits. It's very challenging when you think of that slide a couple of slides ago that give all of these statistics about really low rates of cancer participation. It's easy for us to be deficit minded when thinking about the experience of the community. But actually it's a very vibrant community that has many strengths. And accessing those strengths and coming from that place, we can get a lot of work done together as opposed to just focusing on deficits. Our work has had a real focus on developing relational aspects of our partnership and understanding the need to build trust. It is unfortunately true that, there are strong remnants of mistrust between academic and medical institutions and community groups, individuals and organisations. So when we go into the community to work on engagement and try to develop relationships, we have to be very intentional about trust building and growing trust, because we represent, sometimes what has been seen as distrust institutions in that work. So that's something that we have to kind of strive to acknowledge and overcome in the work you do in community engagement. Finally, I'd say that our work has really consistently and persistently attended to what I would call cultural safety and attending to racial justice. We're meeting today just a few days after the 2-year anniversary of the deadly Christchurch mosque attack. We're in the middle of a pandemic that has had profound impact of communities of colour, including the Somali community. And we're in the process of what's likely to be a pretty heated trial seeking justice for George Floyd. And so all of these events have formed the context in which we do community engagement work. And they all have a profound impact on people's ongoing health and the relationships that we build in community engagement. So in the work we do, we hold a vision of racial justice as central to our work together. And just a little bit of nostalgia here. Here's a tribute that was very routinely posted around New Zealand. That's our national bird, the kiwi, 2 years ago. As there's been ongoing reckoning. And And I can't sort of emphasize enough the impact of Islamophobia on the health of Somali Muslims today. And people you are seeing in your clinics and in your research will have had these experiences. And it's important for us to be really, really careful to acknowledge that as we do that work together. So community engagement and action. What I would like to do is show some examples of projects that we have done with the hope that it inspires and informs people thinking about how you might do community engagement to help with cancer prevention. We have been very lucky to be able to conduct some work in the area of tobacco prevention. I'm going to talk about two different projects briefly. The first one of these was addressing the role of smoking during Ramadan. Ramadan being the holy month of fasting that happens once a year and that we're kind of getting close to starting up here again. And this is work that was done in collaboration with Dr. Anne Joseph, Dr. Kola Okiami and others, and was funded by Clearway. So we were in the position to be able to pilot using tailored text messaging during Ramadan. And this was also a partnership with Darul Hijra Mosque here in Cedar Riverside. It is very common that there's a natural reduction or even cessation in smoking during Ramadan. Smoking is considered by some as haram or harmful or forbidden during the period of Ramadan. And there's also with fasting and the activities of prayer and all of the activity that happens around Ramadan, a real reduction in time at which people are participating in smoking. So we see that there's a real natural window of opportunity to build on those gains and help them sustain. So first off, often people are reducing smoking without any support or help. They're not necessarily using nicotine replacement products. They're often referring to doing this with willpower alone. So there's a need to potentially support people as they go through that. But what often happens is that Ramadan ends and people recommence smoking at much the same rates that they did before. And actually qualitatively, some people tell us they've maybe even smoked more at the end of Ramadan. So this project, in partnership with local faith leaders, Imam Sharif Muhammad, we developed religiously tailored text messages that were delivered alongside messages from the Smoke Free Quit library. So it was a combined health and faith-based messages. And our main goal for doing this was not to necessarily study cessation, although we did have 10% of our sample quit. We didn't ask them to quit, but we had 10% quit at follow-up. But it was to see if people were open to and felt it was feasible to have this period of intervention during Ramadan. And we had great feedback from people that they were very pleased to receive these messages and they found them very supportive. And the fact that we were sustaining a 10% quit with our follow-up data is also very encouraging because those are people who may have ordinarily returned to smoking. So this gives us a great signal that this work had good feasibility, it had a good currency with local community members, and it's really ripe for continuing on as a fully powered cessation study, which is work that we're hoping to do in the future. Again, this is work though that would not be possible without that community engaged input and working together with key community partners. So that's an example of work that I think has been very promising and indeed couldn't have happened without community engagement. A second example around tobacco prevention is addressing youth nicotine use in the Somali community. We know that Somali men in particular smoke at very high rates compared to the general population, and that having a parent smoking is a risk factor for indeed youth smoking themselves. But what you'll see here, of course, is a photo collection of a lovely pile of vaping devices. And this is what's really changed the landscape for nicotine use for Somali youth. We're seeing that there's increasing rates of vaping amongst Somali youth at a higher proportion than their peers. And we already know that they've got these additional risk factors. So this project is a photo voice project, which I'll explain a little bit more in a moment. This is a partnership with Welshare International and is funded by the Search Group and the CTSI. So it's a delightful part of my week sitting down with a group of Somali youth who have been recruited to this project. And what Photo Voice does is it uses images to help narrate or tell the story of a challenge or a topic. We've started out this work by first conducting focus groups with other Somali youth about their nicotine use and their views on nicotine use and vaping. And the youth involved in the project became trained as focus group facilitators. They designed an interview guide, they ran the focus groups together and had some just very candid conversations with some of their peers around vaping and nicotine use in the youth community and amongst Somali young people. From that work, we identified certain themes or areas of importance around what might influence people to take up vaping or other forms of nicotine use. What are the impacts of that? What people do know, and what kinds of things help? What kinds of things are protective? What kind of assets in the community help prevent nicotine use? So we're now on this project's undergoing at the moment. So we're now in the phase of this work where the young people are using photography to help express how they see these themes playing out in their lives and the lives of the community around them. It's been an absolute delight to work with these young folk because they are highly motivated for change in their community, and they have access that I don't, as you know, sadly, neither being so young anymore or as a community member, to hear what people are really thinking and doing, what young people are thinking and doing around vaping. So it's just a wonderful example of how collaborating together as peers and undergoing that training, this group of young people are achieving what I would not be able to do as successfully as they are. So that work is underway, and stay tuned. We will hopefully have findings to share about that in the near future. Another example that we have had the great pleasure to work on is thinking about health literacy and the role of health literacy in general cancer prevention. We conducted, and this was funded by the Program of Health Disparities Research and conducted in collaboration with Darahidra Mosque, a health literacy program that focuses on cancer alongside literacy skills. So often when people are undertaking something like English as an additional language course, the content might be that they are learning through the English language booklets or materials, could be on any topic. In this course, they were all focused on cancer prevention. And we had permission to adapt materials from a community health centre in London, England, who have been doing this work on a range of different topics. So in that sense, you know, we've done quite a lot of work where we've gone out and educated to the community and received their feedback and their ideas. This work was coming out and saying, hey, does anyone want to engage in English language learning skills? And by the way, it's about cancer prevention. So it was a much more diffuse way to tackle the topics around cancer prevention. A little bit less head-on than sometimes we do ordinarily. And the results were really quite remarkable. One of the things that's quite common in the Somali community is it can be very stigmatized to either say you've had an experience with cancer in your own life or to talk about cancer. It can be something that people feel very nervous about. And interestingly, through bringing people together and in the environment of the mosque and providing these materials in quite a gentle way that also offered an exchange of, we're also going to provide an opportunity for skill building. People really were opening up about their experiences with cancer in the context of these groups. On day one, somebody said, well, what's the point of learning about this at all? Aren't you going to just die if you've got cancer? So this seems like we shouldn't talk about it, which is a fairly common view if you've come from a country that doesn't have a lot of cancer prevention. And so somebody stood up in the room and said, well, I've had cancer and it got identified early and treated and now I'm fine. And that's probably the first time in 8 years of the work I've been doing that I've seen a community member actually stand up and disclose their diagnosis and share with others and promote cancer prevention could be helpful. Additionally, partway through the groups, one of the people who were participating actually disappeared for a while. And they asked where he had gone, and he had zipped back to his apartment to get his colonoscopy report, to bring that back to the group and show other people, what a colonoscopy report looks like, photos and all, passing this around the group. And often people think of the community as being really so private about these matters. But there he was, being really prepared to share his experience as a way to encourage others. So that opened new potentials that exceeded our expectations in terms of bringing people together, being in the community, in a trusted institution, and undertaking an intervention which created space for dialogue. So this work also showed improvements in literacy, particularly around confidence in finding information, confidence about accessing professional help and understanding one's provider. So perhaps that people may, get from this something that helps them in terms of their interactions in the medical system in general. And here's just a picture of some of our booklets that we've borrowed here, and you can see NHS on some of these. These are the original booklets. We did some very strategic airbrushing to remove the National Health Screening Service of the UK. But these are examples of the booklets that they have culturally concordant pictures and names throughout them. And this is the booklets on general cancer prevention and mammography and cervical cancer screening. These are all available. If anybody's interested or wishing to use these in their own work, please just let me know and we're very happy to share. Now I'd like to give an example or two around cervical cancer prevention. Women from East African countries actually have very high incidences of cervical cancer, but very low rates of screening, and HPV vaccination rates are quite low also. So this is a perfect storm and very ripe for the potential of prevention in this instance. So in terms of the activities we have undertaken, we have engaged in considering the role of faith-based messaging as an asset. So in collaboration again with the Dar al-Hijra Mosque and Imam Sharif Muhammad, we did a series of work that started out with focus groups with community members talking about the importance of faith to them as they understood health and cancer screening. This led to the development of faith-based messages that we were able to develop into video-based material and test those materials with community members. And then we were able to run community-based workshops with Somali women, Somali men, and faith leaders. And here's an example of the messages. In terms of a faith perspective, the messages very much draw on how Islamic values may promote taking action for cancer screening. An example here on the slide is the idea about modesty. And often we might hear that a woman may be reluctant to show very private parts of her body to medical providers. And so these messages were able to be used in workshops that could create space for conversation about, well, how does Islam see modesty? To open up a dialogue around modesty, that it isn't modest in the right context, to be able to share these parts with a medical provider, and that it is okay and seen as an appropriate thing to do if it's about taking care of your health and wellness. So these messages were able to open and foster some great dialogue in the community, and we found improvement in views and attitudes towards breast and cervical cancer screening amongst Somali women, Somali men, and faith leaders as well. This work, as you'll notice, I just mentioned, involves Somali men, and our community partners actually challenged us to engage Somali men in conversations about breast cancer screening because of that central value of families being a really core unit that we concentrate on this work. And they were very engaged and very interested. And likewise, when we were talking with Somali women, they wanted to know about about cancers that affect men in their family too. And it really reinforces that idea that when we're talking about cancer prevention, that we may not be talking about one condition or diagnosis, that these things are seen as from a family-based perspective, as different cancers who affect different people who are in the family. Another example around cervical cancer prevention is working with some of our clinic partners. And we were able to use a really great innovative method called video reflexive ethnography and working with partners at Smiley's Family Medicine Clinic. Smiley's had been struggling with HPV vaccination rates being at around 10% for their Somali patients, and very graciously and bravely agreed to have us be at the clinic conducting observational field work, where we filmed medical assistants during the first interaction around HPV vaccination and offering the HPV vaccination to patients as they came into the clinic. And the reason I give this example is because community engagement is not only about working to engage community members, but we actually have a community of providers that can also be very meaningfully engaged in thinking about cancer prevention and a part of the potential solutions for prevention. And in fact, this was a very participatory method. Medical assistants had to not only agree to have us there and filming interactions, they were also asked to sit down as a group and observe each other's interactions on video clips we provided to them. The goal of this was not to look for things that they were doing wrong, but to form a participatory, collaborative approach around looking for opportunities for potential improvement, opportunities for thinking about how might we grow to meet the needs of the community. And where are there opportunities to do something a little bit different in terms of what we're doing right now? Some of the things that we identified in doing that is that the medical assistants in general treated everybody just the same who came into clinic, regardless of who they were. So they may be sitting in front of a Somali patient and they might be sitting in front of a white identified patient, and the conversations were very, very different typically in terms of the starting knowledge that people had about what HPV was and how to address the conversation around starting the vaccination series. One of the things we were able to bring into this work was some focus group data we had done with Somali youth, young people, actually between 18 and 25, about their views around HPV. And one of the things that we learned is that they told us, the young people, that there was huge amounts of confusion between HPV and HIV. So here we have the opportunity to watch this practice through video clips of actual real live practice, and to be able to bring into that, to share with the medical assistants, did you know that actually a lot of your Somali patients think you're talking about HIV? Well, that totally changes how you view the discussion you might be initiating. And it also reinforces the idea that people may be at quite different starting places in having discussions about cancer prevention. So what we were able to do through this process is identify opportunities to improve some of the provider and clinic practices. There was two main things that we did. And the first thing was to develop some culturally tailored patient information that addresses some of the key concerns that were coming up in the conversations that were happening repeatedly. And I'll show you that in a moment. And to identify an opportunity to reinforce a clinic practice around always having a second offer of the HPV vaccination series when the provider entered the room next. One of the things that was quite clear in watching the videos is that sometimes patients were flat out declining the HPV series and doing it in a way that wasn't actually very apparent to the medical assistant due to cultural differences in communication. Now, when the medical assistant doesn't recognise that the person has declined, they're not necessarily going to queue in their provider to offer that vaccination again. And so by making it standard work to always offer it twice, regardless of the conversation, in addition to tailored patient information, that really transformed the vaccination uptake from 10% to 30% uptake over the 6-month period following our video reflexive ethnography work. This is the this is the tailored information that we developed. And you can see here that the number one point is to reinforce to people that HPV is very common and it's not the same as HIV. And we don't usually see that information that's provided about HPV in primary care. We were able to pull in some of our faith messages that we've done on other works, and in collaboration with some community partners who help vet this patient information, some faith-based messaging that promotes the idea that prevention is better than cure. Some traditional messages that we might see from places like the CDC about it being safe. But then also this little piece of patient education that's often missing around the impact of cervical cancer for women from East African countries, and to bring into consciousness both for the provider the importance of this, as well as for patients about why this is useful to be aware of. So by developing this information, we're able to bring into the room something that supports the medical provider or the medical assistant and reminding them about the things they need to talk about. But it also provides information that resonates with patients in the community. And we know that through our interactions and our prior work, and in observing the interactions we saw through our field work. So this is a very useful tool for helping support both patients and providers. But you'll notice that the form is also organised in a bilingual format. And that is to acknowledge the fact that, you know, a young person may have a primary preference for written materials to be in English. Well, their parent may prefer Somali. And so by integrating both languages on the one information sheet, it also gives this patient information flyer the opportunity to help support dialogue and discussion within families. Again, this is completely available, and we're very happy to share it. If anybody is interested, please just let me know, and I'm happy to share these files with you for your own work. So just by way of summary, really, just to think for a moment about, you know, all of these small projects come together and they start to work in synergy in terms of thinking about the way our partnerships have led to being able to develop faith-based interventions, brought us more understanding of individual experience, being able to bring us more understanding about the role of the family. And they all start to grow together and make an accumulated effect. But this work started with the first project, and it started with just one first step, and sitting down together and listening to each other and building that relationship. And so my point here is that you don't need to do all these things at once to do community engaged work, but that first venture into doing it, in terms of starting the first project, can lead over time to really quite an accumulated body of work that can start to make a really great impact on cancer prevention when it's so sorely needed. So I would like to just for a moment though talk about some of the challenges around doing community engaged work. And this has been a tough year, and I'm sure I'm speaking to many of you as you're holed up in your home offices. And we're all working in ways that are socially distanced. And that is a challenge also for community engagement work. When we would ordinarily start out with a topic, one of the things we might do is start by getting together and having a dialogue, having a discourse together around what does this topic mean for the community. Well, COVID-19 has changed that dramatically, and our ability to gather in groups the way that we might have usually done this work has been severely eroded. But one of the real strengths of this community engaged work is that our partnership were already in relationship with each other and had trusted connections together, that we were able to mobilise and apply to PCORI for funding to study how can we improve methods of community engagement in this context of COVID-19. So we are just have wrapped up, and we're in the middle of writing up some of our findings from a community-based survey. And ordinarily, we would never do a survey in the Somali community. It is not a preferred method of community engagement pre-COVID days. And so we had to think really creatively about how can we reach out to the community to understand more about preferred methods of engagement. And so our survey used a kind of a crowdsourcing approach where we recruited 40 community ambassadors across the state of Minnesota who are identified as Somali and said, please, here's some money to thank you for your time. Please, go forth and identify 15 to 20 people in your personal or professional networks and help them complete this survey. Whether it's doing it together on the phone, whether it's emailing them a link to the survey, whether it's having a conversation with people in your household. And we got 940 people responding from across the state. That's very exciting to us because it shows us that there's ways to do engagement perhaps even better than we've been doing before. Much of our work focused on very dense geographic areas. A lot of our work was based in Cedar Riverside. But in reaching out around the state, there's actually huge amounts of interest from community members across the state to talk to their own experience too, which are different. Which may be unique. They may be working and living in areas where there's much less community around them, or they might be having very different experiences in accessing health, cancer prevention, and so on. So we asked people, what is the best way to get in touch? What are preferred methods? And you'll notice that we have by phone and text message being really the preferred methods of engagement at this time with COVID. For community engagement. This is not rocket science technology, but it's something that we perhaps haven't done a lot in community engagement before. But it offers us a real challenge that perhaps in moving forward in our cancer prevention work, we can think about other ways to be engaged in community engagement. And you'll see that other online meetings like Zoom, like we're doing today, just about the least preferred. So if you're feeling fed up with the pandemic today, that's a note that you're not alone. Everybody's getting a little sick of Zoom too. We also took the opportunity to ask people, what would help increase your confidence in taking part in community engagement? And this is the work again that we did in relation to COVID-19, but the lessons relate to any community engagement activities. And it really roughly breaks down into 4 areas. The first being, if you're going to do community engagement, show us what the impact is. So people really shared that they would be more inclined and more likely to participate in community engagement if they can see the action and change that comes about from their engagement. That doesn't mean just sharing findings from reaching out to the community, but demonstrating that you're prepared to change things as well, and you're prepared to show how that engagement might lead or influence to changes in the healthcare system. The second thing was to be aware of the process of engagement. So people were very keen on there being proactive outreach, to being really good listening happening. But interestingly, the very interesting dialogue and partnership is being key to the process of engagement. So often people in the community aren't seeing community engagement as something that's passive, that you reach out, people tell you something and it comes back, but actually as relational and starting partnerships through which there can be conversations and action built together. People wanted to see demonstrated representation, to see people who looked like them and the institutions reaching out to them, and to see the development of trusted connections, including engagement of not only community leaders, but community members both. And finally, people talked about they would have more confidence in community engagement if they felt there was a good commitment to the community. So that's about showing up and supporting the community, supporting local community organisations, and being committed to addressing the issues that are facing the community. So these are good lessons coming out of our COVID-related work that we'll continue to bring into our cancer prevention-related community engagement. So where to start? You might be seeing this whole list and thinking, well, this sounds grand, but how can I integrate this into my own work? And I think that some of the things that, I would suggest is, while I'm showing you a great, this big pile of work, it always starts from a first conversation. And the best thing to do is to start by listening. And I think another challenge is to be prepared to follow the community, not a specific condition or diagnosis. So you'll notice our work moves over a number of cancer conditions or a number of concerns. And the thing that I hear quite consistently when I'm doing community engagement is, oh, you're different than those other ones, because when we ask that last academic researcher about a different topic that's just as important to us, they said they don't do that. And you've been prepared to come with us. And I think, I listen to that carefully, but it's challenging, of course, because we also exist in these intellectual silos of the work that we do. So it can feel challenging to step out of the comfort of your own area and be prepared to listen about, oh, so there's other conditions or other things that are of just as much concern for people in the community. And in some ways that reflects that for some people, breaking the body into conditions or organs or diagnoses can be arbitrary. In the community, people occupy their whole body and see their cancer as part of something that happens within their whole experience. So in community engagement, the challenge exists to meet people where they're at with that. Collecting community member input does not have to be complicated. It can be formal, as some of the things I have shown, or it can also start with developing informal conversations. So sometimes when a new idea comes my way, the first thing I might do is pick up the phone to a trusted community partner and say, what do you think? And just continue to really develop opportunities for partnership and dialogue together. In terms of partnership building, some of the key things that can be usefully done is to spend time, finding shared understandings, and that can take time. And I think that an example of that in my work has really been around my growing ability as someone who's outside the community to understand the role of faith and to understand the role of religion in relation to the Somali community. I had, in my early days, just engaging with the literature alone, you would think that faith is something that's a real problem in relation to cancer prevention. And it took time for me to learn through conversations and experience that actually it's a huge and often untapped asset. So finding ways to share and grow our understanding of key issues is important. And that gives us the opportunity to start setting shared priorities together in the work that we do with community partners. It means really taking time to learn from each other and respecting each other's experiences, skills, and knowledge. And I can think of countless examples where the work that we have done has been pushed further through the community partners' suggestions, through the community partners' knowledge, skills, and experience than I could have done alone. And again, just in this particular community, the role of faith is important. You might be working in a different community where that's not so central. So it's about understanding what's central in relation to the communities that you may be working with. In relation to next steps, we are hoping to be able to study the use of HPV self-sampling as a really important tool for cervical cancer prevention in primary care. We're looking to develop the role of testing further the religiously tailored text messaging and fostering smoking cessation, not only during Ramadan, but sustaining quit beyond that. We're continuing to build ongoing capacity in our community academic partnerships. And in particular, I think, taking time to reflect on and learn from the lessons of the last 12 months with COVID-19. That's been a very challenging time, and the community's been very hard hit with COVID-19, but it's given us some opportunities for learning that I think will be valuable as we move beyond and into other areas in our cancer prevention work. So just by way of final reflection, and then we can pause for questions or discussion, is that one piece at a time we can build a comprehensive vision for health equity through community engagement. And it's the experience of patients their families, their community, and providers too as part of the community that can build that vision. It is important, though, to place those experiences in the broader context of the community, systems, and society, so we don't forget some of the things that might be impacting and really burdening community members. One of the things that we found in our COVID survey, for example, is that people talked about it being really important that we understand and research the role of racism in healthcare as part of their experience, and that's going to be work that we can bring into cancer prevention engagement also. And all of this adds up to grow our opportunities for cancer prevention. And that's a worthy and useful thing. So I will stop there and pause for breath, and I'd be very happy to hear any comments or any questions.
People can either type their questions into the Q&A module, or if you want to raise your hand, I'll unmute you to ask your question. Doug, I unmuted you.
Hi, it's Dougie. That was great. And I really appreciate your insight into how to do this type of work. I wonder if you could comment, or and I guess I'll pick out one, the HPV vaccination efforts. How do you gauge success? So are you tracking Somali youth that are getting vaccinated and then have a goal you'd like to reach? And just any thoughts on how you keep track of those data after your intervention is put in place?
That's a great question. Thank you for that. Tracking success is really a challenge, and I think that we're often, one of the real challenges around tracking data in relation to Somali patients is it's quite hard to get that data accurately from many health records. That project's probably one of the easier examples. That's a good question to ask about how we track success, because we can measure changes in vaccination rate over time, and we can measure participation to completion as another objective. The challenge for that is making sure that we have accuracy in data. So when we're working with a clinic as a pilot, we can take a finer tune approach to making sure that we are being really accurate. If we step out a step to the whole system, our ability to determine ethnicity gets somewhat blunted as we move further out. So, you know, I think that there is great potential to do that, and that's the standard objective for us to, you know, start to see equal opportunity participation in HPV vaccination. But I can hear the voice of my community partners pushing back too and saying, how do we define success as something that, you know, again, we can determine in relation with the community. We can determine that through engaging them about what does success look like for them. I think a very interesting example about that comes from a different project, which Anne Joseph and I have been working on, in the Power to Quit clinical trial with smokers who are experiencing homelessness. Now, our standard objective and our outcome is cessation, full cessation, nothing more, nothing less, and that qualifies as a success in that context, and many cessation researchers would agree. When we have dialogue with people experiencing homelessness, they'll often tell us that reduction is what counts as success to them. And it challenges our assumptions around how we quantify and understand success. So we need to pay attention to that question in community engagement work too. What counts as success from the community's perspective may be different than ours. So that's a complicated non-committal answer that just says, you know, personally, you know, I'd love to see equity in HPV vaccination participation. Likewise, if we study HPV self-sampling, we'd like to see rates of cervical cancer screening rise to be equivalent, at least, to the general population. But also we need to remember to engage communities in that discussion around what does success look like for you, and be prepared to have that conversation that it might look different than how we define it.
Hey, thanks.
Say, Rebecca, I'm wondering if you know, so the Minnesota Department of Health has very good immunization records on our state as a whole, including HPV and I'm assuming COVID vaccines, although I actually don't know about that. But I'm wondering whether there are sufficient data or granularity to the race and ethnicity information that they use to be able to look at statewide vaccination rates from that source in the Somali community.
Yeah, my understanding at the moment is that they do not. And there can be some gaps in the MIC data as well around recording immunizations. So this is data that's difficult to put together. It's probably really, there's probably some magical answer there that's about, you know, sort of bridging that gap between health record data and MIC data. This is difficult data to get. But at the moment, my understanding that we do not. And we actually don't generally tend to have ethnicity at the health record level either in a way that's specific. So sometimes it's pretty consistent. If you've got a clinic that's that works with very diverse populations, they might do a much more careful job around recording ethnicity. We can use proxies like preferred language. Well, that sort of changes as we get into second generation immigrant populations and younger people, and this is who we're talking about here, who may have a preferred language of English on their health record. So we start to get larger gaps. So I would be a very big fan of us having more careful recording of ethnicity in our health record and in MIC data to help us answer those questions.
Well, I have one more question.
Please.
Oops, I think.
I can hear you now.
Oh, okay. I think that, you know, in the spectrum of community engaged research, at one end at one end, the research questions are generated by the community and community members. And of course, I'm thinking about the smoking example, but I wonder if you have any experience or examples of research questions that have come from the Somali community about that they would like to see answered about tobacco use.
Yeah, that's a great question. And I think, you know, when we do our work, often we kind of have a little bit of a format. And Anne, I'm just going to note too that Winston made a question around engaging and educating religious leaders. And the answer is maybe a little bit the same, is that, you know, it's not a passive process. So the first thing we might do is share information about where things are at. And because data isn't easy to see, in my experience, when we've had dialogue groups with religious leaders or community members and provided data about the disparities, often people get pretty energized by that. So for many folks, they may not realize that there are these big disparities, whether it's about smoking or other aspects of cancer prevention. So the first step is really to linger in that first space of dialogue where we can say, here's what we know. What do you think? And that's often the point that the research questions become generated. So, you know, using the faith-based messaging in relation to, you know, cancer prevention, one of the questions that comes from the community is about how do we include women who may not be represented as in high rates of cigarette smoking, but might be using vaporized tobacco, such as hookah or shisha. So that would be an example of these discussions where the community has come back and said, well, but hey, if we just focus on cigarettes alone, you're going to leave out women in the community who might be using other forms of tobacco. So questions come from the community all the time, and we continue to take them forward in dialogue. And I think that the important piece with that is to really start with the conversation where we are doing reciprocal sharing around this is what we know. And taking it from there. And that means, you know, going into those conversations, having done our homework as well around what we know from the systems we have access to. But the questions, when we start from that place of getting really curious together and sharing our knowledge, the questions have consistently come from the community, including many of these projects have been community originated too. I think the other part of Winston's question was around engaging religious leaders to around patient medical literacy, and another question around end-of-life care where religious leaders came to the hospital to provide counsel. Yeah, those are great questions, and it's actually something that we've been doing some thinking about with partners around end-of-life issues. And you're right, it all has changed somewhat with COVID. But my experience of working with religious leaders is that I don't do that directly. I do that in partnership with other religious leaders who I work in partnership with. There's a little bit more reluctance to take part in research per se. So that's work we do very carefully together. But it is particularly religious leaders who get really very energized around understanding the disparities too. My experience too of also working with religious leaders, just like working with any religious leaders from any faith, is that when you're being looked to in the community to provide comfort, to provide care, to offer answers, that might not be the time you put your hand up and say, I don't know much about this topic, or I don't know much about this issue. So when we've had work that brings religious leaders together exclusively, so they're in a room of only religious leaders, the questions start coming and they flow. And it creates an appropriate space for people to be able to engage in education and support each other in that. So sometimes I think it's about providing a culturally appropriate space that respects the role that religious leaders have to come together and have those conversations. And then they have access to enormous numbers of people in the community through their own mosques or settings that they work in. So they're very, very important. But that's been the part of our work that's developed more carefully and slowly out of respect for bringing people together in the right kind of context.
Okay, well, we're coming up on the hour, so I guess if there aren't any other last minute questions, we can wrap things up.
Thanks, Rebekah.
Thanks so much.
Yeah, thank you so much.